We're here today with Mark Koziol from the PDA to discuss supervision, and in particular hear his views about remote supervision and if that has a future in community pharmacy. So over to you, Mark.
Thank you. So what many pharmacists might not know is that the whole debate around remote supervision kicked off in 2005. It was a survey that the Department of Health undertook, and they said, do you think that the model of supervision that exists today in 2005 is fit for purpose? Something like 75 or 76% of respondents says no, we need to change the rules on supervision to make it fit for purpose. But what we got is not what we asked for. What we got was this idea of not having a pharmacist in a pharmacy at all, that pharmacies could be supervised by a pharmacist that was not on the premises. Well, that's like somebody saying to you, is your house clean or tidy? Or is it messy? It's messy. It needs tidying up, doesn't it? Yes, that's right. So then they send a bloke in with a flamethrower to burn the whole place. That's not what we were asking for, but that's what we were offered by the Department of Health. The Department of Health then struggled with the regulations to try and take it over the line, and they struggled with it for 6 years. They failed to get where they wanted to, which was the idea of remote supervision, the plan to operate a pharmacy in the absence of a pharmacist. And the reason why they struggled is because they couldn't satisfy the patient safety argument. So then they phoned their friend Ken Jarrell and said, why don't you set up a rebalancing committee? And that was constituted, I think, around 2011, 2012. And they handed the poison chalice to the rebalancing committee and gave them the job of resolving the supervision issue, alongside one or two other things they were also asked to look at. The rebalancing committee then struggled for 8 years, 9 years, and it failed to deliver the solution to supervision, because for a second time now, patient safety was absolutely not at the very, very forefront of all the conversations. And there was continuing to be a move by the Department of Health to create changes to the rules to allow a pharmacy to run in the absence of a pharmacist. Now, we all know that in the end, this paper was leaked by the rebalancing committee. A bunch of people have put forward an idea, it was the subgroup of the rebalancing committee, that actually you don't need a pharmacist at all to supervise a community pharmacy, you could just give it to the pharmacy technicians. Now that was the extent of the desperation to see if they could have a community pharmacy operating in the absence of a pharmacist. The new idea now was just give it to the pharmacy technicians in their entirety. Well, the whole programme ran out of steam because the whole profession was so angry and so annoyed by what was being discussed by this committee that for all intents and purposes those conversations ended, and then we were overtaken by the COVID situation. And now we have a completely brand new initiative altogether. So the rebalancing committee is dead. That initiative is no longer looking at the remote supervision issue at all. It's no longer involved. So what the profession has done, various organisations have got together to say, look, let's craft something that's fit for purpose for the 21st century. So you've now got a representation from all of the various organisations, and we're now starting off a process to see if we can sort this thing out once and for all. Because let's face it, the future for a successful community pharmacy sector has got to be when the pharmacist becomes more available to the public when they come into a community pharmacy setting. We want to make sure that the pharmacist can react both proactively and reactively when patients walk through the door, either with a prescription, with a problem, that kind of thing. Now, you're not going to succeed in achieving that if the pharmacist isn't going to be available to the public in a community pharmacy setting. So, in essence, we want to get pharmacists out of the dispensary and in front of patients so that they can make clinical assessments when those prescriptions come in. So that's where we're coming from at the PDA. We are not going to support any kind of model that allows a community pharmacy to run completely in the absence of a pharmacist. We are absolutely not going to do that. We want the pharmacist to be there, front and centre in a community pharmacy setting. In fact, the kind of model of practice that we are advocating is one where you find more than one pharmacist working in a community pharmacy setting. The kind of place where many GP surgeries, 20, 30 years ago, you had a lot of single-handed GP practices. Not anymore, and as a result of creating those centres where several GPs are working there, nurses are working there, other healthcare professionals are working there, a huge amount of work can be done in that kind of a setting that prevents patients from having to go to hospital, either admitted as patients or as A&E because they can't get seen to anywhere else. That surely has got to be the vision for community pharmacy, because if you think about it, every time the contractors rejoice because they've got yet another remunerated service, the workforce creak and groan. They simply cannot do more work. It's worse than squeezing a quart into a pint pot. So we've got to think about what is it that pharmacists can do, what is it about their workload that enables them to do things or prevents them from doing things. We've got to think about safety of patients, we've got to think about the well-being of the staff that work in a community pharmacy setting. So we need more pharmacists there. So our idea around supervision is that the pharmacist becomes responsible for the clinical checks and the prescriptions. As far as we are concerned, some other solution should be found for the mechanics of the assembly of the prescription. But there's a big $65,000 question there. If we are going to delegate that to pharmacy technicians, for example, we as pharmacists are not going to do that unless we know that if the registered pharmacy technician makes a mistake with dispensing or with licking or with picking or with one of those things, it is they that are held responsible in the law and in the eyes of the regulator for making that mistake. And by all means, the pharmacist will be called into the investigation to account for what it was that they did. But if they can demonstrate that they've made proper clinical checks and that they did not err in their responsibilities to that patient, we believe that the responsibility for the picking and the sticking error needs to rest rightly with the pharmacy technician. Now, the question has been asked whether pharmacy technicians are up for that, whether they are prepared for that. That's a job for the pharmacy technicians to think about. But one thing's for sure, whichever way you look at this, there's got to be a huge investment in the community pharmacy sector, because you are not going to take pharmacy technicians to take that responsibility unless they are properly tested and have the right accredited qualifications, and you've got to pay them significantly more than what they're being paid for now. Now, if you create that framework, you've then got an opportunity to put the pharmacists in front of patients as they walk through the door. You've got an opportunity to put a second pharmacist in who can be doing the lion's share of the consultation room work. This is where the detailed analysis of polypharmacy patients who might have as many as 25 medicines are being looked after, because that's a half an hour intervention that's required there. So you need an IP pharmacist in that space. At the same time, you need another pharmacist who's front and centre of patients as they walk through the door. Now, in the light of the kind of framework that we're talking about, we see there being a really, really vibrant and exciting role for community pharmacy going forward, because for the first time, community pharmacy has positioned itself to do something about some major problems within the NHS system. For we're now playing our role within this new supervision group, and the one thing that we can absolutely assure all our members is every time we reach a place where we can either turn left or right or go up and down with a decision around how it might go, we will be consulting with our members, we'll be surveying them, we'll continue to have focus groups with them, because we need to make sure that whatever solution comes out is one that pharmacists are satisfied and happy to work with, and most importantly of all, has patient safety at the very heart of the solution. So I'm hoping that that will reassure some of your readers.